Hi, everybody. I'd love to introduce Jakob and Nikolas Kather from Technical University of Dresden, who has been doing excellent work at the applied machine learning to medicine. Welcome.
Thank you very much. Thank you very much, Greg, for the invitation. I'm Jakob from Germany. I'm professor of medicine and computer science, and I will speak about AI and oncology and the work that we and others are doing in this field. These are my disclosures here. So, first of all, introduction. My team has about 35 people and is super interdisciplinary. So half of the people have a computer science engineering background or physics. Other half has a medical or biological background. I think it's super important to have this type of interdisciplinary team in this area. I mean, we really have the philosophy that all the medical people and biological people, they should do hands-on software development, and the computer scientists, they have to know what they're talking about in terms of the medical concepts. So really blending these types of expertise basically within every single person. What I will present to you today, and what is the focus of our research, is AI-based biomarkers in oncology. So I'm an oncologist, a cancer doctor. I see patients with cancer who come to get chemotherapy, immunotherapy, other types of treatment. What we are seeing in this field, so cancer is super common, right? 50% of us will have cancer at some point. Half of the population is affected by this at some point. What we are seeing is that the oncology landscape is getting more and more complex. So in terms of the types of treatment that we have available, let's look at an example: lung cancer, metastatic lung cancer, a very common type of cancer. We see this quite often. 10 years ago or 14 years ago, there was were only certain types of chemotherapy available for these patients. Nothing much that we could do except this. Now this landscape has totally changed, and we have basically dozens of treatment types available. So here, what we are doing in oncology is basically we just look at the guidelines that are issued by professional societies, and then we find the closest path to of the guideline recommended treatment to our patients, and then we discuss this treatment with our patients. So here you can see a screenshot from the lung cancer guidelines 2010, 2023, and you can see that this is becoming more and more complex. And what I'm showing you here is just a small part of the whole decision tree. So basically, this guideline is a PDF with hundreds of pages that has many of these decision trees that we try to follow for our patients. So this is becoming much more complex, and what we need is to have decision aids at these points in the decision tree where you either can turn left and prescribe this treatment or turn right and prescribe the other treatment. You want to have some guidance where to go. And this type of guidance is what we call a biomarker. Um, so what we are working on is to use artificial intelligence methods, deep learning, to extract such biomarkers. And we are only interested basically in routinely available data. So data that is available at scale for every single one of our cancer patients. Here I'm showing you some examples. As you know, image data is very well suited to be analyzed with deep learning. Basically, most of deep learning happens in the image space. For our cancer patients, for every single one of them, we have a lot of image data available. We have these pathology slides, which you can see here, the pink bluish slides. This is basically a piece of the tumor tissue that's cut into slices and digitalized, and this gives us gigapixel images where one single image has many gigabytes of dozens of gigabytes of uncompressed file size. We typically compress them into just 1 or 2 gigabytes, and then we have dozens of these slides for every patient. So there's a lot of visual information there, and then there's also radiology images, of course, where you have 3D radiology scans that we do for every single patient, and then there's text data and genomic data that's available at scale. So we are using deep learning for all of these data types, especially we're also doing multimodal data analysis, by which you put these these different data types together. So how do we do this? Well, we basically build software pipelines for this. I will now talk specifically about the pathology image data, because this is a very common type of data and has a lot of information. So to analyze these pathology images, we use, of course, deep neural networks, and they're at the heart of our computational pipelines. Our pipelines, of course, most of the work that we are doing is to pre-process the data appropriately, and then to post-process it and visualize statistics, etc. In the center, we just put the deep learning model. Our software pipelines for pathology image analysis in cancer are open access, available here, will be published as a journal paper soon. So whenever I speak to medical audiences, I tend to show this example. Everything that we're doing in the simplest case is just taking a medical problem and rephrasing it as an image classification problem. So as you know, classifying images in category A versus B is something that's super straightforward, and our task is our unique intellectual contribution to the whole field is just to take medical problems and to phrase them in such a way that we can just treat them as classification problems. In the easiest case, it will be just an image classification problem. So what are the types of problems that we're interested in? Let's say in lung cancer, we have a certain treatment type, a certain immunotherapy. We want to predict whether patients will benefit from this therapy or not. So this is a classification problem. You can take patients, you can put them into buckets, responder, non-responder. You can collect their images at baseline before they receive the treatment, and then you can train just a classification deep learning system on this problem, response versus non-response. So this is basically very easy. The hard part is to find the right problems, to phrase it in the right way, and then to basically get the data and build the pre and post processing around the deep learning model and validate it appropriately. But that's basically it. We never have to create any new neural network architectures or anything off the shelf. Typically works at the core of our pipelines. So what my group has done is to apply these, to do exactly this, to try to find new ideas where we can treat a medical problem as an image classification problem and then address it and try to solve it. So one specific niche that we are pursuing is that in cancer that for every single patient with cancer, we have these pathology slides available, okay? But usually this is just being used to make the diagnosis of a tumor. In reality, we need to have much more information about the tumor. Do they respond to a certain treatment, but also do they have certain genetic alterations? And typically what you do is you take tumor tissue, you send it for sequencing, and then you get the result back, and then you know which mutations are there. So what my group has shown is that you can actually just take the tumor tissue, just an image of the tumor tissue, and then train a deep learning model to predict the genetic alterations in this tumor. So the underlying assumption is that in any organism, the genotype will determine the phenotype. And just by looking at the phenotype, you can basically guess the underlying genotype, okay? And we showed this for a genetic property called microsatellite instability that many people care about, because this qualifies patients for cancer immunotherapies, which is one of the most efficient most effective drugs that we have, and also one of the biggest markets for pharma industry. And we were able to predict this property from images alone with deep learning. So this specific work has been made into has been the basis for a product that's now where this is now approved as a medical device in the European Union. You can also use the same thing for the same approach, basically just image classification for prognostication, right? To a patient who will receive surgery with the intent to cure the patient. We know that, for example, in colorectal cancer or breast cancer, some of these patients will relapse, so the tumor will come back. The medical problem here is we want to be able to predict in which patients the tumor has a high risk of coming back, so that we can give these people additional chemotherapy to eradicate remaining tumor cells. But it's super difficult to predict this. So again, deep learning can provide a solution here by which you train a deep learning model on the images, in this case also histopathology images, to predict in which patients the tumor is going to recur, and in which patient this is not going to happen. And this gives you very, very good predictive power for this recurrence event. Again, an example, this is just another tumor type, liver cancer. In liver cancer, together with collaborators from France, we also showed that deep learning can predict immunotherapy response from the H&E slide. So it's the same story all over. For medical audiences, these are usually it's usually interesting to see that this is possible in different tumor types. But again, from a technical perspective, all the applications are basically similar. So we are, of course, doing some work on this on the academic side. Our output is in the end a publication whereby we show that this is possible in a certain tumor type. Others, of course, many other groups in academia are working on this as well, but also in industry. And this is just basically a random snapshot of headlines that I was able to Google in a couple of minutes, right, where you see where people are using this concept of AI-based biomarkers in oncology, basically using very, very similar techniques to the ones that we are using in our research. What changes things a little bit now in our practical work is the advent of foundation models. So, of course, I don't have to preach to the choir here and explain what foundation models are, but basically from our perspective, what we did for many years is whenever we had a medical problem, let's say we want to predict response to a certain treatment from image data, we collected these data, and that's basically 90% of the work to collect the data. And so we were trying to collect hundreds of patients who were treated with a certain treatment, and then train models basically from scratch on this type of data. Well, now this field has really changed, and we are, of course, not starting from scratch anymore. We're starting with the foundation model that we can then fine-tune on our task. And specifically, of course, we used a model that has been trained with self-supervised learning on hundreds of thousands of on many tissue slides without any labels, and then we fine-tune this on a supervised prediction task. So this two-step process of first using unlabeled data to train a foundation model and then fine-tuning it with labeled data, this really changes things from an applied point of view, because now healthcare data that's completely unlabeled, imagine just pathology images with no additional data whatsoever, no diagnosis, no manual annotation, no clinical data, nothing, just the pure naked images. These are already a useful resource, because with self-supervised learning you train a foundation model on them, and then it shortens your path to a specialized model later on. We have, for example, shown last year that using such an approach, you can improve your biomarker prediction capabilities, which we care about in these, which we care about to be able to predict, to make actionable predictions for patients. So, Greg, yeah.
Are there does this resolve any or all privacy issues with using patient data for analysis if there's no label of any sort?
Yeah. So pathology images without any labels are basically, you cannot reconstruct a patient identity from these. You can so they're anonymous, and to train such a foundation model indeed resolves is not critical in my and many people's view. From a privacy point of view, for the downstream task, the supervised fine-tuning, of course, we need then labeled data, ideally images plus clinical data. Oopsie, yeah, but
and the other one is, can you give us an idea of the kind of information that exists in these pathology slides? Because I mean, it's rather interesting. You can infer genotype and so on. When you train a foundation model, it really is just saying what features there are in this data set. So what are these?
Yeah, Yes, yeah, it's this is sorry, I didn't bring a full pathology slide, but maybe you know what, I will just use this one and go back here and reshare my screen. So this is how these slides look like, and they are I mean, you can zoom in very, very deeply. These are really very, 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 very large images, right? And you can see the individual cells. So here, one of these small blue dots here is a cell, and this is approximately 7 micrometers. So, and you can zoom into micrometer basically level resolution here. So the patterns that are being learned are, you know, just round cells, fiber structures, but also texture properties of these cells. I mean, this is the whole. There's a lot there, and but what we can see is that if you train a foundation model with self-supervised learning on, let's say, 1,000,000 slides, then you can really squeeze out a lot of these patterns.
Yeah, thank you.
Thank you. And by the way, you don't have to train your own foundation model. Well, if you, if you're an academic, you can just use all of these models that were, or there's a long list of models that are available publicly that we use and anybody can use for non-commercial purposes. Usually, if you're a commercial entity, you have to basically train your own model or acquire one. So, but if we're talking about foundation models, we can also talk about multimodal foundation models like vision language models. These are also trained with self-supervised learning on basically non-curated, non-annotated data, but basically image text pairs, right? And of course, these models, such as Claude 3 Opus in this case, also have acquired understanding of medical image data, for example, of surgical videos, such as shown in this case, but also histopathology slide. Again, this is Claude 3 Opus, where you can give it a piece of pathology slide and then ask for interpretation, and then but then of course there's also people have also trained specialized vision language models for pathology. For example, our friends at Harvard from Faisal Mahmoud's group who have published PathChat, which outperforms GPT-4o in most cases in terms of the way to you can interpret pathology slides, and they of course are marketing this now as a product. Another way to interact with vision language models is via few-shot in-context learning. So we did basically a fun study where we evaluated the vanilla capabilities of GPT-4o to classify benchmark datasets in histopathology. So this dataset Patch Chameleon, where you have non-tumor and tumor slides, not slides, sorry, tiles, so patches obtained from these slides, and your objective is to distinguish these. Well, the zero-shot performance of GPT-4o is pretty bad. It's just 0.6 in this binary classification task. But if you basically provide examples in the prompt with in-context learning, and then you can get very, very reasonable performance. Well, just like 10-shot performance, close to 90% here with GPT-4o. So, and for me, this is really fascinating because in-context learning is just such a cool paradigm. You don't have to train anything, right? You just provide your example and you train the model without training it. I mean, this is for me still somehow magical and super, super cool that this also worked for pathology image classification. So the question is, of course, will we need, like down the road, 2-3 years down the road, will there still be a need for specialized models, or can we just take GPT-4o, GPT-6 and apply it zero shot, or if that doesn't work, just few shot on our problems? And I mean, we don't know the answer here. I'm speaking a lot about large language models here, right? In the context of vision language models, but even just the language only capabilities of these large language models are super interesting for us because, as you know, in many cases, obtaining the labels is quite costly for us because in clinical routine everything is documented in unstructured text. So what we are doing is with large language models is to use them as tools to extract structured information from the unstructured text and then use that, for example, as labels to train our deep learning models on. And this works pretty well, and people in the medical field are quite excited about this because this used to be manual work, right, where you would review. I mean, any medical researcher is used to basically spending countless of hours per week to just review unstructured data and extract this. Even in clinical routine, I mean, um, in clinical routine, even in the most advanced healthcare systems, there's so much like redundant, very simple tasks where you enter the same information over and over again in different computer systems, or you read a PDF and you extract pieces of information which you then manually document in another computer system. So automating these tasks is very useful, and it's also useful to generate annotated training data for training deep learning models. What we think is even maybe more interesting for regarding the use of large language models in medicine is the basically what we call talk to your guidelines, right? By which you take, I'm very sorry, there's this example turned out to be in German here, but you can believe me that when you ask a medical question to a large language model, like, should I take antibiotics if my throat aches? Then you will get in many cases, in some cases you will get a good answer, but in many cases you get a superficial answer, which is not totally on point, but you can of course massively improve this if you provide medical knowledge as additional context via RAG or just as part of the prompt. And so what we did in a recent study is to see whether large language models equipped with the oncology guidelines can give us basically medical advice according to the guidelines, and the answer is yes, this works, and this is also necessary. So vanilla zero shot GPT-4o gives you very poor oncology advice for complex questions, but GPT-4o with medical guidelines via RAG gives you very, very high quality responses, which is what we analyzed in this paper. But I think ultimately this is all coming together in the way that we have vision language models that we give visual information, but also textual information, and then also knowledge through RAG, basically. And one thing that we are used to in clinical routine is to draw little sketches for our patients. Okay, what we will typically do if we explain a clinical case to another colleague is that we draw a little sketch of this patient who had liver cancer, and this was diagnosed in July 2018. Then they got 4 rounds of a certain treatment, and then and then the treatment was not effective anymore, and they progressed. Right, so this is represented in a visual sketch, and this is very, very common in clinical routine. Well, in what we are seeing in vision language models is that you can take this visual description, of course, of a clinical case, and then you can give it just to the model, and then enrich the model through with additional context here, clinical guidelines, and then ask it for treatment advice for this patient. And in this case, the model gave us good advice, but of course I'm not endorsing this as a clinical tool, right? This is not approved as a medical device. This can never be used for clinical decision making, and also should not be used to process private healthcare and private individual data from individual patients. For us as scientists, also large language models equipped with tools are very, very interesting, specifically the capability of GPT-4 again to write Python code and execute it, because this can automate a lot of the very simple statistical analysis that we do for clinical trial data. So in this recent publication, we showed that you can use GPT-4 in this case to analyze data sets obtained from clinical trials, but just by using this code interpreter capability, by which the statistical analysis can be designed and then immediately executed. And so this is, I mean, it's still, I think, weird that very few large language model providers offer this in the way that OpenAI does, where you have the option for your model to just in the browser generate the code and execute it and perform this data analysis. But this is for the type of medical research that we're interested in, very, very useful. Ultimately, and this is I'm already getting to the end of my presentation
Actually,
here.
question.
Great, go ahead.
In some cases where it's a vision model, I can kind of see this working pretty much in an automated fashion. Writing your analysis code. But when it's medical, I mean, there's causal issues where you have to carefully design your identifiers. I don't know, kind of interact, saying like you have the wrong confounders, right confounders, instrumental variables. That becomes a much more interactive process. So how does that interaction like become AI mediated?
I mean, in a perfect world, your large language model is just like a trained statistician who can think about these confounders and write the appropriate code to analyze this in your data set, right? But even if not, you can do this, and this is exactly actually what we did here to run the analysis in an interactive fashion, and then but basically in a very short of amount of time, interactively you write the code for the analysis and run the analysis. So that works pretty well.
So then,
as we showed here.
I mean, is there? So I would imagine, actually, even for non-causal, you have your performance metrics are working or not working, or domain knowledge. The appropriate error metric doesn't just depend on this variable, but this variable is important, this variable is not important. So things like that, flow needs to be, what's the word? Dependent and data driven, where the data might actually tell you, no, your intuition is right, your intuition is wrong. So it seems like it's more of a wizard kind of interaction as opposed to a fully generic interaction.
Yeah, I think I don't know if GPT-6 or GPT-7 will be smart enough to do all of this. I mean, this is speculation, right? But let's assume that technology will not progress. It will just stay the same as it is right now. And then these tools just make you much more efficient. Because if you're an expert, well, most of the people that I hang out with, they're experts in the medical domain and not in the technical domain, right? So for them, just using their medical domain knowledge on a large Excel table and not caring so much about the implementation of the statistical analysis is what they need. So that's basically the use case that we're talking about here.
Right, that makes a lot of sense. And then, and this community would be the medical researchers, right?
Yeah, exactly.
Then maybe the other question would be, what's the role of doctors in this? Because you're covering a lot of the processing, the diagnosis. I'm noticing a lot of the sensors are either fancy image sensors or ask the patient the right question. So that in your role for a doctor, ask the patients the questions that but they don't want to, they don't even think to answer.
Yeah, that's yeah, I mean, these are many questions. I do think that, again, with the current technology in all of these things, we need human doctors in the loop, but you cannot imagine how much like boring, repetitive things we are doing in clinical routine all day. So most of more than half of the work that doctors are doing in the hospital is just a substantial part of the work that doctors are doing in the hospital is just documentation, very, very low level things, and just automating. I think that's the selling point that we're trying to make, to automate these away as soon as possible, and then do the exciting stuff, which is talking to people, touching people, basically working with our patients, and you know that the like computer, basically digital technologies, computers do not have the best reputation in medicine, because it was promised, like in the last decades, it was always promised you switch from your paper note to fancy computer systems and then everything will get better. But guess what? It was the other way around. The computer, any electronic health record that we use in clinical routine, it totally sucks, right? You press a button, you wait 100 milliseconds, you do this like thousands of times a day, and this makes you just crazy. And so there's even study that poorly decided that electronic health records are one of the main contributors to physician frustration and burnout. So you cannot imagine just how bad all the software is that we have to interact with in clinical routine every day. And this is really, really, really frustrating and really an issue. And so I think here would be another chance to show that with a new technology, we can actually make life better rather than make life more miserable for healthcare providers.
Then then let me challenge you there is, in what ways can this make it more miserable? Imagine less autonomy for doctors because guidelines are just sitting on their heads and they can't make independent decisions.
Yeah. I think there's many ways that this new technology could make life more miserable for doctors, and we should please avoid this.
Makes sense. Yeah. Thank you.
Thank you. As talking about doctors, what we are doing basically often this is a small part of the work in oncology, but it is an essential part where, for example, we get a referral of a patient who has already received a lot of different tests, and they come with a bunch of documents and images, and then our task is to look at all this and then look at the guidelines and then recommend appropriate treatment, right? And this is specifically something which I believe can be automated through large language model based agent systems, right, where you couple basically different types of have models where you take a large language model that interprets a prompt, and then you give it access to knowledge, to knowledge databases, clinical guidelines, scientific literature, but then also you can give it access to a specialized radiology processing models and genomic analysis models, pathology analysis models, and then a large language model that sits in the center can basically relay the data to the right downstream model, to the right tool, and then get the response back and then give you a recommendation based on all of this. And this is, again, not something that I'm endorsing here for clinical use, because this is not approved as a medical device, but this is something which we have shown in this recent preprint, in a recent preprint, that this basically works for very complex cases in oncology. So I guess that's that's what everybody says, that agentic systems are somehow going to be the future, and I do believe that in healthcare this will also be very, very interesting, because inherently you're dealing with very different types of data, and I think it's unlikely that you will have one single multimodal foundation model that's trained on every type of data that you can find in healthcare. I find it much more likely that we will have a large language model sitting somewhere, being equipped with different tools to analyze specialized data and then integrating the result again in the end. So basically, I'm getting to the end of my talk. This is just the last AI gone wrong slide. So again, whatever we do, we should not blindly trust AI. When we ask in the beginning, when we had the initial image generation, models, it was very easy to get like failure cases. Now it's getting increasingly harder, but one case that still works pretty well is you ask Dolly 3 to generate anatomical drawings of human organs, and you get some things that are maybe correct, but maybe are wrong in some details that are pretty crucial, and then also you get some spectacular failure cases. So do not blindly trust AI yet is a message that I always end with. And again, this is now the end of my presentation. And if you have any questions, we can still discuss. Thank you.
Yeah, well, thank you very much. It was fascinating. So first of all, are there any questions on the call? Like anybody on the meeting? Okay, so then one question I had was, so you're going to have these foundational models that are trained on data from where data exists, rich countries. So you're going to have a data imbalance of, one, income levels of the countries, but all medically speaking, racial divides where you just have far less data of some racial groups because they live in the countries where they have less data. So how can you deal with such data imbalance issues for medical treatment quality?
Yeah, that is indeed a big issue, right? In Europe, in most countries we have some kind of universal healthcare, right? So no matter who you are, whether you have a job or not, you will get and if you have cancer, you get the most recent treatment for your cancer, including immunotherapy that costs a couple of €100,000 a year. So the inequality to healthcare access is, of course, much lower it's not non-existent, but it's much lower in Europe than in the US, of course, where most people, where many people just don't get state-of-the-art treatment because of a lack of healthcare access. So I guess these systemic things are also relevant for AI, because in our hospital you just have if you just go to our university hospitals here, you have a cross section of the population, right? So all the part of the population are represented there and are being treated there. And I think this is also good if we train AI models on these, because we then train AI models on basically the whole population. Of course, there's still deprivation for certain groups, but this is much less pronounced, like in the universal healthcare system. In the US, this is very, very pronounced, of course. And in general, everywhere you have to counteract it consciously, right? So you have to basically make sure that your data sets contain the whole diversity of people that you hope to apply your AI model to in the end. But and we do see that it does make a difference. You mentioned different countries. This is, of course, also a relevant thing if you want to market your AI model in a certain country. And then you have to validate it from this intended target population. So this is something that we are very, very mindful of.
Yeah, so then how would you control for that? I'm thinking especially for foundation models where you just kind of toss a lot of data at it, hoping for the best, but practicality wise, you're going to get, I'm thinking, I don't know, skin color is an easy one for dermatology, where the same lesion will look different depending on the underlying skin color, and your balance of data will just mess up the quality of your model.
Yeah, I think it's just about getting the right mixture of data. So get the mixture of data that represents your target population, and then train your model on this. I don't think that engineering, like conscious engineering, can like oversampling, undersampling, synthetic data generation, specific loss function. All of this is just over engineering. Just get the type of data of the population that you want to apply your model to. And if you only have patients of a certain ethnicity in your data set, then be conscious, in your training data set, then be conscious that your model is not going to work outside of this population. I do not think that better models, better engineering of loss functions, of some engineering tricks will help us here at all. We just have to get the real data and the real diversity, and then we have to validate it. So if you are aiming to to build a model that can be applied to anybody in a certain population, well, then you have to show empirical proof that your model is working in this population.
That makes sense. And then one area which you didn't touch on very much is the domain knowledge in the underlying area. I'm talking about maybe you'll have like prevalence of cancer in coal miners, lung cancer. That may be in text data, but I'm also thinking of how the underlying human biology works, how the internal dynamics of the immune system. How relevant is that for final medical diagnosis, or is that just an implementation detail that's going to be in PubMed somewhere? Or do you see that being explicitly given, or for these high-level medical models?
I mean, that is the domain knowledge in developing and applying these models certainly helps. I think the main aim should be to avoid building things that are like, for domain experts, are totally and obviously irrelevant because they don't address the relevant use cases. And I think I think what's always better, what's always the best factor that guarantees that your models will, or that makes it more likely that your models will solve a meaningful problem, is to have a single person who has an idea about the domain and an idea about the methods at the same time. If you just take a pure software engineer and a pure doctor and you put them in a room and you give them the task to build something meaningful, it's not going to work because they speak essentially different languages. I believe that it has to be within the same brain, and then you are very efficient. Well, this is what we are trying to do in our training programs.
So then, beyond it's all in one brain, if what it has to be, I'm thinking actually, a whole body analysis. So you have like it seems like now we have the technology to incorporate information from many different regions of the body. So I'm thinking an immune response causes something in the brain because the immune system hits everything, but you don't have any one expert like that. Or like a prion disease. Well, now somebody has to understand proteins. So it has to be a team of people or modelers who create a team of models that maybe an LLM combines, but it's not very much a multi-domain kind of a solution or a problem.
Yeah, that I think, that's true. I guess you're right. Yeah.
So then, it seems like some of your approaches are hinting at that, where you have an LLM kind of federating such models, but I'm not sure to what extent you can integrate them more deeply. I don't know if you have thoughts about that.
No, you're right. I mean, my only thought here maybe is that in any case, mechanistic knowledge is in medicine, in many cases, having empirical validation of a certain treatment, of a certain diagnostic tool, is more important than having the exact mechanistic knowledge for the clinical routine. It's a different case for the biomedical research, where you aim to develop new approaches to a certain disease, but but you can there's many things in medicine which you can do just with empirical knowledge, and not without any underlying mechanistic knowledge. Yeah, that would be maybe another point.
Right, that makes sense. And then speaking of this, so for a causal inference or treatment effect estimation, that's its own beast of, and this is something that LLMs are not, that has not been translated to LLMs or those foundational models, saying that because you did this treatment, that was the outcome, and you've done all the confounder control and whatnot. So to what extent can those
we almost never, I mean, this causal thinking, again, it's maybe a bit provocative, but what counts in the end in medicine is to have the empirical validation. There's so many drugs that make sense because they might steer the immune system in this direction or in that direction, but 99% of what makes sense will fail empirically, and so I mean, this is the problem of drug development, right? You start with like 10,000 drug candidates, of things that make sense biologically, and then you go through steps of empirical validation, and it narrows down, and in the end you just have a handful of drugs. And the reason why they work, why you use them in the end, is not because they have a beautiful biological theory behind them, but because they're just empirically proven to be effective. So in many cases, in the practice of medicine, we are biased towards having empirical evidence rather than having a deep systems understanding of what we're doing. Of course, in the best case, we need to have both, and you need to have the deep systems understanding to develop something new. But in the end, what we do primarily relies on empirical, basically empirical validation.
So then, is there promise? Okay, ultimate validation is always going to be some randomized control trial, which are horribly expensive and so on, and in some ways impossible, because if I'm valuing a surgery, the best trial is drag people off the street, give them surgery, see what happens. That's my truly randomized group. So what I have to do is more like like diff and diff, where I have a patient, I have a control patient that's almost like that, and I just don't give them the treatment, or better yet, in the wider population, look for statistical hints that indicate this kind of treatment is working out. So then, these technologies may be able to make increase the yield of causal inference from widely available data. I'm actually have in mind, use the text data as processed by LLMs as the control variables. That if this person talks like a smoker, conditioned on that, lung cancer. But I don't know how far this new technology can aid in that inference.
Yeah, I agree. I think having these causal ideas will of course change your pre-test. Having some additional information changes your pre-test probability for certain things, like you said, the smoker, the person who comes into the room and is and you see that they're a smoker, that they are smoking. They have a pre-test probability that's different from other people. So indeed, it's about. But for me, this is again empirically integrating different cues into one probability in the end.
You mean that just different feeds? Like, these are more inputs to the model.
Yeah, exactly.
Yeah, I think where I'm worried about causally is the reason why causal matters is if your data came from a random distribution, like randomized control trial, but for data, great. Causal is everything is causal. Where it breaks down is if your data collection is biased, that the typically if the dynamics of your lung cancer treatment are correlated with the whether you get measurement, like who you're going to get measurements from. Like if you mostly get measurements of smokers, any lung cancer propagation model is going to be biased towards the dynamics of a smoker. So in order to fix that, you have to condition on smoker status, or I don't know, do they talk like a smoker, which is really what you have. So I'm not sure how many other kind of confounders, actually, maybe that's really what I'm asking. How many confounders can you identify from data without having to be smart about it? I guess that's the promise of this technology.
You're right. I mean, that's a fundamental problem for many things that we are doing in medicine, and I don't think that just better engineering will solve this. Like explicitly factoring in another potential confounder. I mean, I don't think that you can consciously make this. I just think that typically what we want is just more data, more diverse data, and data from the real. And from the real world, right? If you train a model you don't even have to have a model that works on the whole population. If you have a hospital, then the people who walk into the emergency room in the hospital, they are different. They're not maybe representative of the whole population of the area, but we want your model to work in these patients. So the answer would be just train your model on exactly these patients, and then you would be very confident that it will work on the patients that come in the future.
Yeah, so that's actually a good example. So that's the kind of bias. Well, it's weird. You want it to work for humans, but you really, really want it to work for people who come into a hospital. So having a mild bias towards hospital visitors is potentially a good thing.
It's good. It's what you want. Yeah.
Yeah. So then maybe last question, at least for me, is if you have, so I mean, just the human application of it. If there's, in what ways can you imagine the medical care system changing to make better use of this of these technologies, whether it is tracking patients better or employing medical staff in a different way? Like, what's the right interaction point or transformation for in a lot of these technologies?
Yeah, I mean I think there's two problems that these technologies will hopefully be able to solve. One is information overload, right? We have 20 years ago, it was much easier to know everything about breast cancer than now. I mean, now even one person cannot know everything about breast cancer, let alone everything about any cancer or any disease, right? And that's the information overload. So to cope with information overload, we need assistive systems. And I think it's pretty clear that, that especially the advancements that we are seeing with large language models can help us cope with the information overload, because just Googling something often it doesn't help you. But then in the future, I mean, the idea is that using a large language model based assistant to parse all of the existing knowledge will help you cope with the information overload. The other thing is, of course, shortage of healthcare staff, and that one reason for this is that healthcare personnel spends a lot of time with non-meaningful tasks like dual or triple documentation in computer systems, right? And taking this away is basically freeing up time for the things that matter. Is I think the would be the promise. Also taking time away from boring tasks or from easier repetitive tasks toward more complex tasks, such as reading a chest X-ray, something that for a radiologist is really among the easiest tasks. Reading a series of whole body MRIs at different time points is a much more complex task where you want to redirect your time to your time at. Yeah.
That makes a lot of sense. Well, cool. Thank you.
Thank you very much.
Then, I think we're good. Well, thank you. Have a great rest of your day.
Thank you. Have a nice day. Bye-bye.
Bye.